Thank you all for joining us for this week's Miami Global Brain Tumor Symposium. Before we start the formal introduction, I just want to kind of play this short video from the Neurosurgery Research and Education Foundation, just introducing kind of their initiative, which I think is a very important one. So while we wait for the rest of everybody to join, I'm just going to play that and then we'll come back. You guys see that?
Yes, we can.
My name is James Badu, and I'm one of the neurosurgery residents here at the University of Miami. I know we all keep extremely busy schedules, but all I'm asking for is just a few seconds of your time. A few seconds just to look back on your journey to see where you started. Whether you're a neurosurgical attending, fellow, resident, or even a patient, or a loved one of a patient who's been touched by neurosurgery, take a moment to think about how you got to where you are today. I'm confident that every one of our stories involves someone who selflessly invested in you, someone who gave and gave so that you could have a brighter and better future. I know that that is my story. Now it's our turn. It's our turn to invest in the future of neurosurgery. The AANS, in collaboration with the charitable arm of Amazon, known as Amazon Smile, has started an initiative with the Neurosurgery Research and Education Foundation, also known as the NREF. The NREF's sole purpose is to brighten the future of neurosurgery by investing in a variety of innovative projects, research, and fellowships. Some of those projects include things like spinal cord injury,
peripheral nerve surgery,
neurosurgical oncology,
vascular and endovascular neurosurgery,
spine, skull-based neurosurgery.
And it's as simple as using the Amazon account we all have.
Let's invest in the future together.
So, will you join us?
All right. So thank you for letting me introduce that. I think that's a great initiative by the NREF, and for anybody who has an Amazon Prime, they'll donate for free 0.5% of anything you buy on Amazon to neurosurgery research and education. That goes to scholarships and grants for all of our residents and medical students, and so I can't think of a better initiative. But let's get to this week's Miami Global Brain Tumor Symposium. I'm very, very excited. We have really an A-team this week for the symposium. Just quick introductions. My name is Michael Ivan. I'm one of the neurosurgeons here at the University of Miami, director of our research program and our psych disease director for neuro-oncology. I'm joined tonight by Dr. Komatar, who's professor and program director of our residency program, also director of the UMBTI and surgical neuro-oncology. Dr. Morkos, who's professor and co-chairman of our department and director of our skull-base and cerebrovascular program. And Dr. Benjamin, who's assistant professor and director of our skull-base dissection laboratory called Kane's Lab. Each week we put this on. I think we're in our 24th week, and I can't do this without the help of our amazing administration from both the neurosurgery department, University of Miami, and Sylvester, Christina, Roberto, Ingrid, Yamari, and Ignacio. Thank you so much. For anybody who wants to know more about our symposiums, you can always find us on social media. We're active on Twitter, YouTube, Instagram, and this is our website. So each week we post what the next symposium is going to be, and if you want to register for any of them, you could always see. And in addition, every week on Thursdays, we run a similar symposium focused on cerebrovascular and skull base. And this week we have another exceptional program put together by Dr. Morkos with Dr. Caldwell and Dr. Hyman. So please join us tomorrow night for the same time, the same location. Also, a quick preview into next week's Brain Tumor Symposium. We will be welcoming Dr. Suidain from Sloan Kettering and Cornell to talk about diffuse intrinsic pontine gliomas. Housekeeping, so please, we try to make this as interactive as possible. Please use the Q&A button at the bottom, and we'll ask Dr. Kalkanis and the rest of the panelists the questions along the way. We don't offer CME, but you will get an email confirming your participation. And please be sure to like, follow, and share our videos on social media so that we continue to grow and share all the outstanding knowledge of our speakers. So getting to this week's panelists, we really have an amazing group of surgeons, starting with Dr. Nahed, who's a surgeon, a neuro-oncologist, and brain tumor surgeon from Harvard and MGH. He's the associate professor and associate director of the MGH neurosurgery residency program, and is just an outstanding researcher. Dr. Aman Kular, who is also assistant professor, director of adult neurosurgical oncology at Pittsburgh, also a physician scientist and outstanding brain tumor surgeon, and Dr. Sherman, Associate Professor and Director of the Surgical Neuro-Oncology Eastern Campus at West Virginia University, also a phenomenal brain tumor surgeon. So we can't wait to hear from them. Tonight's panelist is very, very special. Dr. Kalkanis is joining us from Detroit. Dr. Kalkanis is internationally recognized brain tumor surgeon, and we're very lucky to have him tonight. He received his undergraduate medical degrees at Harvard, and then in 2014 became the chair of the Henry Ford Department of Neurosurgery, where he serves at the co-director of their Neuroscience Institute. Most recently, in this past January, he also was appointed as the Chief Executive Officer of the Henry Ford Medical Group, and Senior Vice President and Chief Academic Officer. He oversees over 1,900 physicians and researchers in this position to try to push the mission of precision medicine in their medical team. Clinically, he's very, very active with brain tumor research, clinical trials. He runs as a transitional research laboratory looking at molecular genetic differences in short and long-term brain tumor survivors, with a goal on future personalized medical treatments for brain tumors, which I'm sure we'll hear a lot about tonight. He's also served as a visiting professor over 100 times and has more than 150 publications. And if that wasn't enough, he also serves as the president of the Congress of Neurological Surgeons and also as a director of the American Board of Neurological Surgery. So his plate is very, very full, and we're very lucky to steal a few moments away from him tonight to share with us his thoughts on innovation in personalized medicine and brain tumors. Dr. Kalkanis, thank you so much for joining us.
Wow, thank you, Mike, for that incredible introduction. I'm very honored to be here with all of you, and just so thrilled. When you talk about an A-team, the A-team is right there in Miami. Dr. Ivan, thank you for putting this together. Dr. Komatar, Dr. Morkos, and Dr. Benjamin, and so honored to be with such exceptional colleagues, Brian, Duca, and Jonathan. Look forward to a great evening with all of you. So I thought I'd start just by, over the next few minutes, hoping to give a little bit of a tour of where we are in brain tumor surgery in the precision medicine era, and certain innovations that are available to us. And the title of this, More Than a Faster Horse, will become available. The meaning of it will become more obvious toward the end of the talk. But I think we're living through an inflection point, not just because of this crazy, surreal year, but also because of all the advancements that have come to neurosurgery and our ingenuity. And so I bring you greetings from Henry Ford in Detroit. It's a beautiful day here, and we hope to welcome many of you in the future. We have about 32 faculty on staff in our department here, including not only neurosurgeons, but neuro-oncologists, neurointensivists, and neuropathologists who are part of our team. Again, I can't thank the team in Miami enough. You all are leaders in taking advantage of technology to bring us closer together in a time when we need to be socially distanced and not able to travel. This symposium, I think, really has brightened the educational opportunities. I certainly have enjoyed it along the way for so many of our trainees and colleagues, and it's a great way to stay in touch. So thank you again, and thanks so much for the honor of being here with you today. So what I'd love to focus on is just a discussion about how we, over the next period of time where we have these new tools at our disposal, how can we improve detection, treatment, and outcomes? And there are several things that we can use, including advanced neuronavigation, minimally invasive surgery, and specifically targeted precision medicine treatments and other technologies. I think about the last century, or at least half century, when you think about glioblastomas as not very impressive compared to other advancements in medicine, but we're starting to see some movement. And, you know, you have to go back to the 1990s to see a little bit of a blip on improvement of the curve when navigation was introduced. BCNU impregnated wafers helped life expectancy a little bit, 13 weeks. And then the Stu protocol with temozolomide, Avastin therapy helped a little bit. But what I'm most interested in is another timeline that's superimposed on this, which is really a timeline of our molecular genetic understanding of how we can personalize treatment for patients with brain tumors. And this actually started a couple of decades ago with our understanding of 1p19q and then MGMT methylation. Of course, most people now are familiar with the IDH story, but how we can go beyond that and think about epigenomic and genomic alterations to really get a handle on liquid biopsy for informing treatment and also enhancing other therapeutic options. So before we do that, we have to set a foundation. And many of you on this symposium have been involved in the guidelines effort. And the GBM guidelines, as sponsored by Organized Neurosurgery, have been pretty clear. Maximal safe surgical resection is the gold standard. And if that's not possible, then at least getting a tissue sample is critical, given the importance of understanding what our molecular and targeted options are. But you can't stop at surgery. The cartoons at the top really are meant to reflect the fact that even if you take out every bit of an enhancing tumor, a part that's visible on a scan, you're already left with cells that oftentimes have crossed the midline. So you need adjuvant therapy. And so the so-called STUP protocol, where we're giving radiotherapy concurrently with chemotherapy, temozolomide, is something that's well known. So this is our starting point, and the question is, what can we do beyond this? Well, over the years, we've learned that if you happen to be a patient who has a methylated MGMT promoter, you respond more favorably to temozolomide. We also thought that you needed to get more than 98% of the tumor out surgically to gain any statistical significance in survival. And this was oftentimes a deterrent for surgery, even as recently as a decade or so ago. But what we now understand through many investigations, that really any bit of surgical resection, more than 3/4 of extensive resection, 78%, really does impact survival, and it helps with our understanding of the underlying molecular genetics. So what we've done at Henry Ford is try and take advantage of this by really doubling down on investments in our tissue bank. We're proud, along with MD Anderson and several others, to have contributed to the Cancer Genome Atlas, and some of the early work that came out of this was an understanding that people are different when they respond. We all see in our tumor boards in our clinic very similar patients, but some patients are very short-term survivors, others go on to be very long-term survivors. And early on, we identified several molecular markers that were upregulated, as you see here in green, in very short-term survivors, and those same signals were exactly downregulated, as you see here in red, in our long-term survivors. So this was an impetus to really understand some of the early molecular and genetic underpinnings of this disease. And right now we're focusing not only on liquid biopsy, but in certain microRNA pathways that inform this diagnosis. At the same time, we also have an opportunity with newer technology. I spent a lot of time here. This is OR32 at Henry Ford. It's our intraoperative MRI suite. And, a lot of people were skeptical when this first started. This is our 10th year using this technology, and now we're advancing and also doing it concurrently with 5-ALA, which I'll touch on in a second. But it really does matter in terms of our ability to get the proper extent of resection, especially for low-grade tumors. We know that this extent completely correlates with quality of life and survival. And even for malignant tumors, we can potentially double survival times when you can be especially aggressive in the safest possible way with resection. And the thing I like most about these technologies is that you can add on other adjuncts. So we do a lot of awake surgery, as all of you do, including DTI and functional MRI, which really helps plan our technique. And this was actually from the very first case we did a decade ago, and I still show it because under the microscope, under loops, under the naked eye, under any modality we had available at the time, we thought we were done with the case when we got to the image at the bottom left. That looked like normal brain, but thanks to intraoperative imaging, we knew, in fact, that there was a rind of tissue left behind. So we went back and got out that remaining tumor. And this may or may not have been a coincidence. I'd like to think that it wasn't, but this is one of the very proud few patients that we call it a craniversary, but essentially this was a patient who was our first case in the intraoperative MRI in 2011 and is alive today. So to me, it's really made me a believer in extent of resection and in targeted adjunctive therapy. So we also used advanced tractography, which in many ways is sort of like Google Maps in the brain. And, this happens to be a view from one of our synaptive technologies, but there are many others that are in use as well, where you have rotating holograms of the brain in real time that are then superimposed on the video screens as you're operating, so you can see what you're doing and where your targets are. Thanks to Dr. Lee at our institution, we also employ quite a bit of lit therapy. We use thermal ablation, laser thermal ablation for many indications now. It used to be for really limited to brain mets refractory to stereotactic radiosurgery. We now are doing it for focally recurrent primary malignant brain tumors, and even some first cases that are in maybe difficult to reach surgical locations. And the goal here, for those who may not be familiar with this technology, is not to burn or boil the brain, but really to get it in that sweet spot of about a 45 to 60 degrees Celsius range. And it's time dependent in terms of the thermal damage. And we hook ours up directly to the intraoperative MRI, so we can see the heat map being developed in real time. As you see here, you see the lesion being created. And the good news is that you can actually set temperature limiters around the lesion so that it automatically turns off when it gets to a more normal brain. And with that, as you see here, it keeps this a very, very safe procedure, such that you can actually get within a millimeter of the brainstem and not really cause any untoward effects. And again, our patients make me a believer. So this was our very first case from 6 years ago, and obviously a very difficult location. You all know the life expectancy of someone with a lesion like this, that's a malignant glioma, and that it's in a difficult to reach area. The next day, we kept getting serial images because it was new technology. We were worried that we caused more harm than good, given the bit of expansion. But over time, there was a little bit of internal dissolution of the tumor, not much edema. And believe it or not, this was a scan from earlier this year, and this patient is still alive. And so, I think that, again, used properly, having lit in the armamentarium is something that it has been very useful to us as well. But what about other surgical adjuncts? I've also become a believer in 5-ALA. ALA, the non-fluorescent ALA, the way it works, it's taken up selectively by malignant brain tumor cells. We don't know exactly why, but we think it has something to do with the disruption of the blood-brain barrier, increased neovascularization, overexpression of membrane transporters. And what happens is that it utilizes the protoporphyrin 9 pathway such that when you shine a polarized light onto this tissue, it turns a very bright magenta, pinkish red color. And so the patient comes in, they drink this substance right before surgery. And we took this all the way through the FDA a couple of years ago. It's been 3.5 years now, and I think it's come into wide use. This was the very first case I did, and I saved the picture because it reminded me of the cute Netter type diagram cartoon, because in real life it actually did look like that. When the polarized light was put onto through the microscope onto the patient, the malignant tissue really did emit this red-violet light that was very illuminating, pun intended, for the surgeon to guide in real time. And when you combine it with intraoperative MRI, as I'll show in a minute, you really can enhance your resection. And so oftentimes what will happen is that, as you see here, you think you're done with the case, but then at the very end, there's a wisp of this pinkish tissue at the base of the cavity that says, you know what, it's time to be a bit more aggressive, even though the tissue looked pretty normal. So a couple of our chief residents and others at our institution did a study looking at really a systematic review, but also writing up our own experience of combining 5-ALA with intraoperative MRI. And our experience confirmed a pretty interesting synergy. And what you see here is that this was an intraoperative picture where we thought, all the tumor had been removed, but you see on this top panel marked A that the intraoperative MRI was really showing some significant contrast enhancement in what we thought was likely residual tumor, but the 5-ALA did not show any enhancement. It really was not a vibrant pink blush. So we really thought, okay, well, maybe 5-ALA doesn't work. And we went back to the operating room to go after what we thought was remaining tissue. And in fact, the pathology showed it was just hypercellular brain parenchyma and actually some fragments of some gel powder, but there were no tumor cells. So in this case, fluorescence was actually a more accurate picture. And here's something in the opposite realm. So sometimes the tumor does fluoresce through the cortex if it's close enough, and it'll guide you in as you're doing surgery. This was a case of a 60-year-old who had a prior low-grade lesion that likely transformed. She presented with left hemiparesis, and this was in a pretty eloquent area in the precentral gyrus. And, during the case, we did it awake. The patient was still spontaneously moving her arm to command. We stopped the resection because we thought, okay, look at this intraoperative MRI picture on the top right. We were all proud of ourselves. It looked like we had a great resection, and the patient was still moving, following commands. And so, why tempt fate? We stopped there, but we had a lingering concern that, as you see here, there was quite a bit of fluorescence still remaining, even though the cavity looked clean to the naked eye, it looked clean under the microscope, and it looked clean on the intraoperative MRI picture. And unfortunately, this patient went on to have a very early recurrence, and we think it's because that fluorescence was real, and it demonstrated numerous foci of disease and cells with really positive histological margins confirmed by the pathologic sampling. So that made me a believer in 5-ALA, and I think when combined with intraoperative MRI, it really can help you see around corners. But in addition to stopping and starting and getting a scan, it can really provide some real-time estimation as to how to go forth with the case. But there's more to it than that. And I know we have Dr. Nahed on the call and so many others who are really world experts in liquid biopsy, but our small experience here at Henry Ford has taught us that there's real potential power in this technique. And one of the very interesting things about 5-ALA is that it provided a bridge to our thinking, because EGFR V3, which is the same microvesicle pathway, the biomarkers recovered from blood, showed that same biomarker in the samples of 5-ALA. And so it turns out that when you use enhanced reverse transcription in peripheral blood, it actually could detect these levels correlating with tumor. And we thought, well, could there be a role for liquid biopsy using this technique? And here's a study several of us on the call did together a few years ago, including Dr. Komatar, looking at EGFR V3 and precision immunotherapy for brain tumors, and obviously showing an amazing result here. But again, being able to track this in real time through microvesicle analysis. So you're given a situation that all of us are confronted with where you have similar pathology on imaging. These could all be GBMs, but in fact, one is an abscess, one's a lymphoma. You still need a tissue diagnosis to confirm what you're doing. And one of the tantalizing questions is, what if all you needed was a simple $8 blood test? What if you could detect circulating biomarkers in the bloodstream that would guide treatment? And so one of the things that we're trying to do here at our New Cancer Institute and at our Brain Tumor Center at Henry Ford is take advantage of our tumor bank. And so we see about 900 brain tumor patients a year, and we have about 2,500 tumor board evaluations every year from those patients. Currently, we have about 6,000 clinically annotated specimens that go back 25 years. And the cool thing is that we have about 1,500 of those who have matched serum samples over the past decade. And so we really sought to figure out, could we show a correlation? Could we go back and predict, knowing what we know now, how they would do, and then what could we do prospectively? And so one of the things that we've developed is this avatar model, where every single patient with a brain tumor at our institution, when they go to the operating room, we take some of the tissue. Obviously, most of it gets sent to pathology, but we keep some of it. We send it to the lab through a process of enzymatic dissociation. We create these patient-derived xenografts. We implant them in a mouse model. That mouse becomes an avatar for that patient with that patient's actual tumor. And then we do an intense degree of molecular profiling, sequencing, drug testing, and so forth to really see if we can bolster an analysis for clinical trials or get at a targeted treatment based on these studies. And so one of the things that has come out of this is an interesting opportunity for liquid biopsy. And it turns out that you can measure both cell-free DNA and RNA in the circulating blood, and these so-called epigenetic biomarkers are pretty stable and pretty reproducible. So we set out to do a study looking at epigenetic liquid biopsy for glioma. We had 52 patients with new gliomas, 39 were high grade, 13 were low grade, and then we had 14 healthy volunteers. And it turned out that 96% of these patients, 50 out of 52, we could correctly diagnose the fact that they had a malignant brain tumor. And in fact, we also could compare their molecular subtypes, including IDH1 status, EGFRV3, and so forth. And even if they were low grades, we could detect those as well. The interesting thing to me is that we thought we had 2 false positives. We had 14 healthy volunteers, but 2 came back positive. Turns out it was only 1 because the other patient, a woman, actually went on to develop a breast cancer, and she actually got a mammogram as a result of her participation in this study, and turned out that she did have a carcinoma. So we think that this had statistical power, and we did several other age correlation samplings. We looked at brain-specific probes to make sure that there wasn't any overlap with other body tissues like bladder cancer and so forth. And we compared our training data sets for this liquid biopsy experiment to our entire high-grade glioma tumor bank, and it was the expected correlation. So here's what we found, and essentially, if you look on the left side, this is the blood, and if you look on the right, it's the corresponding patient tissue. And then there are about 15 molecular epigenetic markers that we feel tell this story. And in fact, all of them correlate, same intensity, same color. The only thing that's different is the normal. So the normal tumors, they're not tumors, the normal patients' blood is on the left, normal tissue from, let's say, epilepsy specimens and so forth were on the right. That didn't correlate, and we think that that had something to do with maybe these brain-specific probes leaking into the serum, maybe because of the breakdown of the blood-brain barrier. But either way, there was a high degree of correlation, and showing that there was some specificity and sensitivity to a high degree. So then we looked at 8 specific epigenetic areas, and we found that they actually predicted not only tumor versus no tumor, but IDH mutation status, mutant versus wild type. Again, serum on the left, tissue on the right. And so this got us very excited, thinking that, okay, we have a proof of concept now. What about our longest term survivors? Can we see what's unique about them and replicate it and try and change the genetic footprint, as it were? And so currently what we're doing, and we're almost completed with the first phase, is a prospective study taking blood samples from any time a patient interfaces with our department. So coming in for a consultation, getting their first MRI, getting surgery, their post-op visit before they start radiation, after they're finished with radiation, their second and third rounds of chemotherapy, and so on and so forth, with an attempt to try and correlate, because our thought is that the value of this is not really to diagnose, because you're always going to need an MRI, you're always likely going to need some surgical intervention. But can you predict response to treatment? Can you change directions mid-course? Why wait 6 weeks or 3 months for an MRI when you can know maybe after a couple weeks if the treatment's working, or really trying to use new interventions to try and get a better outcome? So more to come on this, and I know that many great people and sites around the country are working on similar protocols, but hopefully a vexing question that we all get in our tumor boards over time is, is this pseudoprogression or is it true progression? And in fact, perhaps the goal would be to really answer that, and then start treatment to the point where we can really change the survival curve. So when we think about precision medicine, the whole point is looking at what appears to be a homogeneous group of people diagnosed with GBMs, let's say, and really understanding that they are extremely heterogeneous. And if we knew beforehand, by way of genomic testing and DNA profiling, which patients would have a good response versus no response versus a side effect or a bad response, we could modulate treatment accordingly. And our history of how we grade and classify our tumors also, I think, will change very rapidly in the future, because currently we name our tumors based on what they look like under a microscope, oligodendrocytes, form oligodendrogliomas, and so forth. But we now know, or we think we know, that through this molecular genetic analysis, the contribution of these bad actors, let's say an IDH wild-type mutation, some of those do contribute to so-called low-grade tumors. And so now perhaps we understand why some low-grade tumors behave like high-grade tumors, and patients with them have poor survival. So when you look at stratifications of survival in Kaplan-Meier curves, the ones showing molecular subtypes are much better indicators of prognosis and tumor biology. On the left, it's tumors graded by how they look under a microscope, but on the right, they're really stratified by their IDH status, and it really gives you a better sense, regardless of the type of tumor, of how someone's going to do. And I think that more and more we're going to be classifying tumors based on their molecular genetic subtypes. And our current politics notwithstanding, the cancer moonshot from a couple of years ago by former Vice President Biden really helped start the GBM Agile trial, which we're excited to be a part of. It's really now just getting off the ground. It was inspired in many ways by the death of Beau Biden. But what this is essentially a real-time molecular genetic tool to understand if there's a patient in Tokyo or London or Miami or Detroit or Boston or anywhere in between, that people would know in real time, not having to wait a year to publish a result on 50 patients, but understanding which treatments were rendered with which molecular subtypes to figure out as a field and as a profession which treatments are working and which aren't, with making adjustments in real time. So we hope to have our first set of results from this study in actually a few months. And so the key here, I think, moving toward the future and being innovative, is really understanding the role of a cancer biorepository and data sharing. And then you can dream big. And, we all wear wearable devices, and we all heard about the buzzwords of machine learning and artificial intelligence, but what does that mean really and truly for precision medicine and for neurosurgery? And of course, there's a spectrum of what big data can do to really impact our daily life and the lives of our patients. But you can imagine that this is no longer science fiction. So for instance, already today, there are iPads being outfitted with touchscreens that can pick up early signs of Parkinson's disease. There are sensors in toothbrushes that pick up an increased risk for celiac disease and monitor sort of blood levels in real time. There are implantable vascular flow bots that sort of track throughout the cardiovascular system and look for blockages and arrhythmias and so forth. This is what's really cool about living in the age that we do, but it gets to this concept of a pre-vivor, and it's just a play on words, but it's a survivor of a predisposition before you even get the disease, or even before you know you have the disease. And so maybe if brain tumors could follow this course, we really would take a giant leap toward making glioblastoma something more like a chronic disease rather than a death sentence. And of course, there's so many challenges ahead of us, not the least of which is data storage. But the real issue is not only data storage, but the analytics. And the analytics and the interpretation of this data really is the choke point, the bottleneck of this funnel. And I think that by working together and by having institutions like Miami and so many others that are partnering and sharing data and collaborating, we will get to the other side. And one of the things that we're excited about is the NIH All of Us research program. It's sort of like the old school Framingham project on multiple steroids. It's really an attempt to sequence 1 million Americans, and not just sick people, but healthy people, to understand their genetic diversity and what drives certain disease processes. We're honored to be part of this here in Detroit. I know that Miami is as well, and I think that already this is yielding significant insights into the molecular genetic makeup of certain diseases. And so for us, we tried to take all of this and build a fully integrated precision medicine program where any cancer patient, but specifically our brain tumor patients who come to us, do get molecular testing. That is bumped up against what we call a similar patients tool, looking around our region and around our country to see what treatments have been rendered before and what the outcomes might be given a certain pathway. And so when you think about what it means to go down this road of precision medicine, there's so many technological advances, there's so many scientific advances, but with this explosion in new targeted drugs, just when you think you're onto something, you realize that, you know, it's only one step up and there's an even higher summit yet to climb. But I think slowly but surely we're getting to a point where we can better understand this disease. And so to that end, a few cool innovations that we've tried to work on in our department is a portal. It's a software package called OnConnect that links patients and referring physicians and their molecular and genetic subtypes to available clinical trials and treatments regionally. And so a couple screenshots show something like this. You know, it gives the patient demographics. It lists the various subtypes and molecular characteristics of this particular tumor. It then links it up with open clinical trials in the region. Here it happens to be the Upper Midwest with Henry Ford Hospital and a few others that I'm certain you've never heard of before. I'm just kidding. But you know, we try and collaborate well with our partners and really make sure that it's not, you know, centered on one institution, but just making sure the patients get the right treatment at the right time. And so here you see this particular patient's course and with the various imaging that can also be imported and so forth. And so that has really helped drive patients to the right treatment at the right time. We're also working on Raman spectroscopy, which is a relatively new thing, but it's what's old is new again. The technology was actually developed a century ago by Professor Raman in India, and he actually won the Nobel Prize 2 years later. It was the fastest turnaround ever. And this so-called Raman effect is something that's way above my level of understanding, but essentially when you shine inelastic light onto any surface, structure, or entity, it emits, and because of that unique scattering, it emits a unique spectral fingerprint, including for living tissue and including for brain tumors, as it turns out. And this technology was developed over a decade ago by the Department of Defense. There was a first attempt to try and really characterize radiation, particulate matter in the air, improvised explosive devices, and so forth. But it took a huge machine, and it took minutes to hours to really get the results. And there was really a lot of difficulty with sample validation. But because of paradigm learning and because of all the advances in technology, it actually became relevant for medicine. And so we looked at our tissue samples. We took about 500 blinded samples from our tumor bank, and through this technology could really delineate between benign tissue and precancerous tissue and tumor tissue. And it turns out with a very, very high sensitivity and specificity within the span of a second or less, we really could determine using this Raman probe if something was anaplastic or actually fully malignant tumor. And so what we wanted to do is put this technology on the end of a navigation probe, much like we're all familiar with. And given this advancement in technology and microprocessor abilities, it could now fit literally on the tip of a pen, or as it turns out, on the tip of a probe. And here's what we get in the operating room when we've been testing it. So it's both a color and sound feedback to the surgeon in real time, whether or not it's normal tissue, tumor tissue, or necrosis. We patented this a few years ago and now have done a few studies where compared to at our institution, it takes almost a half an hour or 3/4 of an hour to get a result back from frozen section. Here, within a few seconds, you can get, no matter what tissue sample is tested, whether or not it's normal, necrotic, tumor, or even infiltrating, it gives a reliable Raman fingerprint and feedback in essentially real time. And so for us, rather than waiting a significant amount of time to get that go, no-go decision as you're trying to attempt resection, now within a few seconds, you really can help the surgeon, I think, better understand what the intraoperative course should be. So this is a way of trying to say, we can do better. And I think, the old response of just waiting for an MRI to see how you did, much of the time, you don't really know if the drug or the treatment that you gave is reaching its target. You don't understand the molecular mechanism of action, and it takes a long time. Whereas, all of the smorgasbord of activity that we mentioned today with not only intraoperative imaging, but biomarker analysis, Raman spectroscopy, the 5-ALA, and so many advances in tissue sampling, you can actually get to a point where you can imagine personalized targeted therapy within a day. And this potentially could revolutionize the field. to the point of really being a game changer for these patients. And so now about this faster horse, because I am from Detroit, I am from Henry Ford, and I have to put in a car analogy somewhere. And when you think about precision medicine, I think it can be very daunting to think, gosh, we have to change the entire way we practice medicine in many ways because of this technology. But look at what the world has done before. And there was a very famous quote from Henry Ford himself, who started Henry Ford Hospital 105 years ago. And he said, thinking about innovation, if I had asked people what they wanted, they would have told me a faster horse. And in fact, he thought differently. And within really the span of a little more than a decade, it changed the world. So this is a picture of Fifth Avenue in New York City in 1900. There's literally one automobile. But a decade later, you can no longer find the horse. And it's not so much about the rise of the car industry, but if you think about the infrastructure that it took to pave roads and to develop gas stations and just a whole, economic underpinning of how to make this transformation, it's not dissimilar to the task we have before us with really thinking about life in precision medicine terms. So with that, I think there's a lot of work to be done, but there's a lot of great people and great institutions around the country that are helping with this. So really excited to sort of zoom into the future and figure out the next steps. And I just wanted to say, and I couldn't give a talk and be with my friends in Miami without acknowledging that this year was supposed to be a lot different. And we had a big, awesome celebratory meeting in Miami planned for the CNS last month. And in fact, Dr. Nahed is on this call, was the mastermind and scientific program director and leader for this. But we had other plans thrown in our way this year. But the good news is we are aiming for a combined extravaganza next year. So I really hope that 2021 allows all of us to get together in person. And actually, in Detroit, if all goes well, we hope to be hosting the Senior Society meeting next May. And so hope to see many of you here. And again, thank you for the opportunity to present.
Thank you so much. That was an outstanding talk, and just to touch on so many different areas of brain tumor research. I think each one in and of itself is truly impactful, and to have a program where you're able to tackle so many is impressive what you guys have put together there. So you should be very proud of that. So while Brian gets his slides up, we have a bunch of questions here. Let me see if I can just get to a couple of them. Let's see. Alexandra Ortiz asks, what criteria is used to determine the extent of resection when making a decision between, is it, I guess, a 5LA, is it bleeding through? Do you find like 5LA bleeds through, I guess the tumor is what they're asking, or is it actually malignant cells? And how do you make the determine as the pink color fades away where to stop if you're in a non-eloquent area?
Yeah, I love this question, and I just saw it, and I think it needs to really be highlighted, because for me, the answer does not lie in whether or not you believe in the technology or the bleed through or the vibrance of the pinkness or whatever. Nothing can take the place of judgment and surgical know-how, and that's why these are called adjuncts for a reason. You have to put the patient's safety first, and so if you're in a portion of the brain, a part of the brain that is safe and that a little bit more resection, if there's any, equivocal finding on 5-ALA or even on intraoperative MRI, then yeah, you're going to go ahead and be aggressive and take it out. But if you're in an area where even a little bit more could jeopardize a patient, these technologies don't matter. At the end of the day, you really have to think of that first, and that's why a lot of these cases, quite frankly, we've done awake, especially when we think we're going to get into some eloquent areas. So I don't think there is a rule. It's an excellent question, but I think it's surgical judgment and how aggressive you would ordinarily be in that area, pretending you weren't using this technology to begin with.
And maybe just one more question, which I think is kind of interesting, is where do you think we are in the future with the integration of machinery, technology, and robots in neurosurgery? Where do you kind of see it going there, and how much of a role will they have?
I used to tease my colleagues, and I still enjoy doing it in ENT and in urology about, well, you guys can be replaced by robots, but never a neurosurgeon. I'm not so sure anymore. You know, I think that, you know, there may be ways for image guidance, and especially when you link navigation to treatment. So when you think about focused ultrasound, which I did not touch on today, or even if you could couple things like Raman with an ablation, so that, you know, you could use technology to get you onto a platform where it could make a determination of what's tumor versus not, and then treat it directly. There could be a robotic component that does that, you know, alongside. And I think that to me is very exciting. But again, there is no room for error in the brain. And so no matter what technology you're using, it will not take the place of your surgical and anatomical judgment.
Okay, great. A lot of other questions, but I want to get to our speakers because we have some great topics here. So Brian, do you want to head us off?
Sure. Well, thank you to Mike for putting this together, and obviously Drs. Komatar, Norikos, and Benjamin, and all my panelists. Dr. Kalkanis, it was an amazing talk, and I look forward to being on a panel with Nduka and Jonathan. Mike had asked us to highlight it, at least one case each, and I think that as a panel, I'll open it up to the group, but also to Steve and Mike, and obviously the co-directors. And then I will touch on just very briefly liquid biopsy, because it's one of not only my own interests, but something I think we all share in an understanding and a hope that it will ultimately have some larger value. So let's see. When we talk about brain tumors in 2020, Steve touched on this really eloquently. Neurosurgery as a field has advanced largely by a very few number of actual innovations. The operative microscope obviously was a tremendous addition to our ability to microsurgically remove anything from tumors to clipping aneurysms. Obviously, mapping has gotten better every single year. And even in my short career, that's been something that's very palpable. This idea of navigation and whether you're using a stealth or a brain lab system certainly can help. And then the intraoperative adjuncts, whether it's an MRI, a CAT scan, or which I'll touch on is the ultrasound as well, has given the surgeon the ability to leave the operating room with a lot more knowledge that they've removed everything that they can't see through their loops. As you can see, our fields, our neuro-oncology, our radiation oncology, our neuroradiology, and obviously our neuropathology colleagues have all advanced tremendously, and it's time that neurosurgery catches up. So in the spirit of highlighting a case and talking a lot about what Steve has discussed, this is a 53-year-old gentleman who comes in with a left frontal non-enhancing lesion. It's quite large, it's pretty diffuse, and amazingly, his only symptom is aphasia. And what you can see here in this non-enhancing aspect is the MRI demonstrating, again, a left frontal lesion in a right-handed person. Now, because of the language dominance, we obtained a functional MRI, as we usually do, a good, credible credit to our neuroradiologists who are fantastic at MGH, and I work with them so often that their fMRIs are almost always correct in exactly the location that they so painstakingly spend time developing. Here again, because it's in the brain lab system, it's flipped, but this is actually the left side. And what you'll see here is that Broca's is in yellow, the arcuate is in green. And what you'll notice, you can see here hopefully you can see my cursor, in the bottom right-hand screen, you can actually see what this person actually has is some element of Broca's function, if you want to call it that, as you can see up here in the front, as well as behind the tumor. And then, as you would imagine, everything else is kind of displaced posteriorly, giving the surgeon a pretty good window to try to resect this lesion and hopefully get it all. Now, for those who do a lot of these, the things that give you a little bit of pause is this area right here. This little haze here that then very likely is starting to get close to motor. And in fact, we did not only a language, but also a motor fMRI, as well as reconstruct the DTIs and the cortical spinal tracts. And what you'll find here is that you've got the lesion again. Here, the cortical spinal tracts are painted in purple. You can see them probably more elegantly in the coronal section. And then we have overall both lip as well as hand motor. And those are both highlighted. Now, again, if you look at the sagittal, it gives you a lot of confidence that you'll be able to take out probably all, or at least very close to all of it. But the part that will give you a little bit of pause is this part back here posteriorly. And in fact, that's what we encountered intraoperatively. So when we took the patient to the operating room, we were able to did it while they were awake. We did language mapping as well as motor mapping. And the key to this, to do it safely, is not so much the cortical, but rather the subcortical mapping, particularly as you get to these posterior areas here. I won't get into the controversy as to whether or not this T2 and flare is something resectable or something tumor-based, but at least in our practice, we take it to the extent of a maximal resection that's safe to the point where we see function. If there's ever a question, either you can use adjuncts like ALA, or in this case, you could just take samples and send it to the pathologist. And almost always what you'll find is largely normal brain in these corners with some areas of tumor. Now, this is just an example of sort of the pre and post, and to Steve's point about the importance of an intraoperative MRI, we were lucky and have one. Actually, it shares between two rooms. We were able to confirm the resection. And what you could see here is that this is on the post-op MRI, and you can see a resection of everything except for right in the posterior part where it corresponded to the cortical spinal tract. And we left that where we got a little bit of motor function. And that in an awake patient is always somewhat slightly difficult because they can have tonic movement of the motor, but long and short, we were able to resect except for a very small amount of mass. This is a coronal seen in a gatto, just to give you an impression, because it's hard to tell on the T2 with all the stuff from Surgicel. But again, a great resection, took it right to the ventricle, and we were able to stop. Now, this was done 5 years ago. The path came back as anaplastic astrocytoma, IDH mutant, P53 mutant. The patient underwent chemo and radiation, and then afterwards did 12 months of temozolomide. He's doing well, and this is actually his most recent scan from literally this month, with no further, I would say, recurrence. But if you see this little part right back here, this is the part that we left, has remained stable. So the question we have to the panelists, as well as to Steve and obviously the co-directors, is what would you do in this case if you knew a little bit about the molecular characteristics prior? Now, it's a large mass that's got to come out, but does it matter if it's IDH mutant or IDH wild type? Does it matter what the TERT status is? Does it matter MGMT? Now, Steve touched on a lot of the adjuncts that a lot of us have access to and some of us don't. But to be honest, I like the MRI, the CAT scan is great, but I actually use the ultrasound more reliably than the MRI. And if you use it for a while, what you can start to see, this is not the same case, but you can see a mass here, you can see blood flow. And then this little stuff is the stuff you talk about that looks like the T2 and flare around the cavity. It clearly looks more abnormal than traditional tissue, but it's not exactly like the mass. And certainly when you end up resecting a mass, you can end up seeing there's a nice cavity, and then there's these areas around which almost always correspond to either blood, or if you can clear the blood, then it'll let you know that in fact there's a mass there. So to get to Steve's point, and really the point of this talk is how do we let or drive decisions on biomarkers? This was taken from a review on the cutting edge of what's happening currently. And whether you're looking at circulating DNA, RNA, if you're looking at exosomes or extracellular vesicles, or what our lab does is look at circulating tumor cells, this idea that you can actually use the blood to detect tumors, and not only do that, but drive care, is something that I firmly agree with Steve that is definitely going to be the future of care with neurosurgery. So again, a patient will come in, they'll come into the hospital, they have an MRI that'll look abnormal. They're almost definitely going to end up getting surgery just for the sake of getting rid of mass effect, but also just to do a gross total resection. As Steve said, the extent of resection really does matter in terms of survival, regardless of mutational status, but especially because of mutational status. Once they have that, it'd be really nice to have a blood test that you could then follow as they go through and get chemo radiation. And while an MRI will look great, it's really the post-op, post-chemo, and post-radiation, the ones where you have to determine if it's recurrence or not, pseudo-progression or not. That's where, at least in our belief at Mass General, and it sounds like also with Steve at Henry Ford and elsewhere, that there truly is a need for liquid biopsy, and there's a lot of amazing groups around the country and internationally looking at this as well. So I'll leave it to my panelists to talk about either this case or other cases. Hopefully I've also confirmed Steve's belief that in fact the liquid biopsy is definitely something that will be an adjunct, much the way a lot of the intraoperative microscope, MRI, ultrasound, and CAT scan have been. I'll turn it over to Mike.
Yeah, I mean, great outcome on that patient. I mean, great surgery, nice job. Do you think that if you had a liquid biopsy beforehand and you knew the mutational status beforehand, before the first surgery, at the very beginning, that would have changed anything in your plan?
Yeah, it's a great question, and one that comes up at national meetings. And also, I think in general, I think the role of a neurosurgeon is to remove the mass and get a gross total resection when safe and possible. And I'm a big believer in I do a lot of awakes and even do it for non-eloquent tumors. And I think to the extent that you can take out everything that looks grossly abnormal, it's always going to benefit the patient. Now, on the other hand, if you knew that it was an IDH mutant tumor, or if you knew there were favorable characteristics to get a gross total resection, I think that would only further drive your belief. But on the other hand, I would argue that even with an IDH wild-type tumor, it would make sense to get a gross total resection when possible. Where I think liquid biopsy will replace surgery is in thalamic biopsies or brainstem tumors or things like that. Whereas other than that, I think it'll be an adjunct.
Great. And the other question, obviously, this brings up the idea that these low grades are very heterogeneous and that there's hot spots within them. And even though your pathology showed this is a grade 3, it's very likely that that small part that was remaining is probably not a grade 3, it's probably a 2, because you had such a great outcome. And so do you think that, knowing that information, as Steve was talking about, with this ability to kind of look at perhaps the tissue diagnosis and the subtypes as you march through those zones of tumor would be helpful?
Yeah, no, I think as we become a lot more sophisticated with this, things like Raman or intraoperative sampling, even quick molecular assays that we may be able to do at the time of surgery will have significant value. I have no doubt, Mike, as you said, that in fact, the tumor is so heterogeneous. And it is the nice thing about, similar to the tumor being heterogeneous, I think liquid biopsies are heterogeneous. So, our lab focuses both on extracellular vesicles as well as circulating tumor cells, because in not every patient are you going to find a CTC or a circulating tumor cell, and you'll need something else. And I think as you look at those things that are shed into the blood, you'll end up seeing a little bit of that heterogeneity of tumors. And it may not always be representative of either the entire tumor, but if you sequence them or get them sequentially, like Steve was mentioning that they're doing with every patient, I think that gives you a lot of value as to try to figure out what's happening.
I've kind of wondered, first of all, the ultrasound, I'm a big fan as well. I've had access to intraoperative MRI since I left fellowship. So, I love the ultrasound, and I feel like it's helped get a better resection in combination with something like Gleolan. But when it comes to like liquid biopsy, I've kind of wondered, it's kind of like we're talking about for metastases when you talk about, pre-op radiation. If you had, and we don't have the drugs right now, but, if you had a liquid biopsy that gave you potential information about the genetics of a tumor, and you pre-treated with some type of chemotherapeutic or something, or some selective inhibitor, then you could maybe make that infiltrative nature of the tumor shrink back, and it could make your resection more. I wonder, have you thought, is that something that's come into play, or as you've moved with your lab?
It's certainly it's a really great point, and we were able to do, or are able to do, fish-based assays just on the circulating tumor cells that we're able to capture, and then you can imagine ultimately you'll culture them and test a lot of drugs. And I think, as Dr. Sherman mentioned, you imagine at some point there might be some way to give chemotherapy targeting a tumor and possibly making it easier to resect or certainly shrink. I think that all of those are possible. It's just a matter of having the drugs catch up to kind of where we are, at least with other cancers. There's no doubt in my mind that we're trailing with brain tumors, and we got to catch up. And I think to the extent that we can drive a lot of these decisions with real-time data, that's really going to help. It's still odd to me that, for example, that patient, we keep calling an IDH mutant grade 3 tumor from 2015, and we've given him a lot of care, and we're still treating him with that same pathologic diagnosis. So to get to your point, I think both before and also after surgery, we're going to want to know that real-time data so that things like the Agile trial or others can be more meaningful.
Great.
Yeah, Brian, I think if I could just jump in real quick, I think, the one thing that we have to add into this calculus is also the fact that with a low-grade tumor, there's going to be some plasticity that occurs. And so, to Mike's question earlier, I think the way that I would look at this is, in addition to, having your liquid biopsy and and whatever intraoperative markers, if there's an area of tumor that makes you stop because it's functional, then if you get a good enough resection, what we often find, and I think many of us in the room have experienced this, is that with time, you get movement of function, and then you can actually go back and resect that. In fact, Brian, I sent you a patient that I just resected that falls exactly in that same category, because he moved to Boston. But he's a guy who was very functional and didn't want to lose any speech, and if you get a good enough resection, then you're lowering the number of cells that would that can transform. And I think that's what it comes down to biologically, is that you're lowering the number of cells that can transform, and then you buy yourself time to be able to act later on, especially when it comes to IDH mutant tumors. So
yeah, I couldn't agree more.
Great. And Duke, you want to share your case?
Yeah, let me share my screen, see if I can. All right. You guys able to see?
Yeah, it looks great. Thanks.
All right. So, I think so. My name is Nduka Moncolor. I'm the director of adult neurosurgical oncology at Pitt. And it really is an honor to be invited to be a panelist here. Dr. Kalkanis is someone who I have great respect and admiration for, and actually Brian Nayhead and I went to med school together, and John Sherman preceded me in fellowship at Sloan. So it's a tight knit group, and as Dr. Kalkanis mentioned, that it was a real bummer that the 2020 CNS meeting couldn't happen, because as a tumor section scientific program leader for that section, it was we had a great program planned. But I know, but this is really why I love this symposium, is that the symposium has sort of filled a lot of the space that CNS that we miss by not being able to have CNS. So what I'm going to talk about is very, very straightforward, and I'm going to talk about really how my approach to personalized brain tumor therapy, and the fact that it's not really, we talk about personalized medicine, but personalized medicine is exactly that. It's personalized. It's not, each individual has a number of characteristics, and we tend to focus on their on their biological characteristics as the factor that really personalizes therapy. But there are also social characteristics and their individual characteristics that we have to think about as to really be I guess real doctors. And so personalized medicine happens every day. We're just trying to make it better. And to that point, the case I'm going to present is that of a 33-year-old woman with a left motor strip, what was called a pilocytic xanthoastrocytoma, who presented to our institution 3 years ago with another surgeon, and was experiencing focal motor seizures of the right hand. She was biopsied, and the biopsy was consistent with WHO grade 2 PXA. So this is where the personalization starts to come in. So this mutation has a BRAF V600E mutation, which we know underlies many pilocytic astrocytomas. But in addition, the patient also has loss of the P16 CDKN2A pathway. And so that tells you something about this tumor. You're already able to personalize this case, because this is a pilocytic astrocytoma that's gone bad, right? Or that has a capacity to go bad because it's got a mutation in the cell cycle pathways that would normally restrict tumor growth. So the oncologist called me because this patient wanted to get pregnant, and they were concerned that there might be progression during during her pregnancy, as sometimes happens, although it's not completely clear when patients progress during pregnancy. But she's neurologically intact, and she has this tumor. So, again, we talk about, what's the next step in personalized therapy? Well, you have to have functional imaging, and at our institution we use not only functional MRI but also MEG scanning, and what I find is that MEG is actually much more beneficial for motor localization, and functional MRI is more beneficial for language localization. That's just sort of anecdotal, but what we found is really that this tumor was in motor cortex, and so the idea was, how do you resect a tumor that's in motor cortex in a completely normal woman with 33 years old and wants to get pregnant? Then the answer is you get information. So is that information going to come from a blood tube? Is it going to come from an MRI scan or another sort of functional image? There's lots of ways to get information, but in this case, the way we chose to get information was with high definition tractography, which has really become the workhorse at our institution. Not just using DTI, but really advanced HDFT to analyze the white matter pathways. And so what you'll see first is the motor region, and you'll see that sensory region. You'll see that sensory really is surrounding this lesion, but you can see that there's a little tiny hole within sensory cortex, which I'll play a couple more of these. So this is the SLF, and the SLF is completely lateral to the lesion. But what we're trying to build an anatomic pathway. So we already have a genomic understanding of this lesion and what would cause it to progress. And the next step is, well, what's our anatomic pathway to actually resect it? So here's motor. And so we can see the motor fibers are slightly anterior to the lesion. You can see the motor fibers draping over the lesion, suggesting that there might be a very, very narrow window that you could take. And so this is one of the lessons that I try to teach my residents, but all of us, all the panelists know, is that there are multiple ways to get to a tumor, and as an intrinsic brain tumor surgeon, you have to think about what modality allows you to cause the least harm. And given the totality of our information, we realized that it was going to be a transsulcal approach. Sorry, this video doesn't seem to be showing up. But basically, we did an awake surgery. We mapped the patient. We were able to localize both motor and sensory, and we were able to identify a transsulcal approach into this lesion, and you can kind of start to see what the transsulcal approach would look like. It was again right through the central sulcus, coming down diagonally from lateral to medial into this lesion, and you can appreciate that after resection. Sorry, I'm trying to see if this is, but I can't see the panel on the right, but hopefully it's a post-op. But after resection, we were able to get a near total resection of this lesion. And another point in terms of personalizing care is also the surgeon approach. So I prefer to do these cases awake with motor mapping because doing a sleep with continuous MEPs, I think that you don't know what the threshold is for causing injury. So I'd like to, I want to be able to see what my threshold is. And in this particular case, we got to a point where we started to get a tiny bit of hand weakness, and it was very, very subtle. But I knew that this 33-year-old woman didn't want a major deficit, and so we were able to resect this tumor completely, with the exception of a small nodule laterally. And so it'll be interesting to see what happens to this, very small nodule, but we're able to get 95% of a tumor out that would otherwise be considered unresectable in many cases. So the patient did do quite well. She was the most important thing is that she had her frequent seizures actually declined dramatically, and she was discharged on post-op day 3 with 4 out of 5 hand weakness. And this, I'm sure this video is not going to play, but let's see. Oh, actually, it will play. So this is her post-op, and again, we're right in her hand region. And so I think hopefully this sort of displays the combination of the use of genetic information. If this was a pure pilocytic astrocytoma, we probably wouldn't have, we would have reassured the neuro-oncologist and said, let her get pregnant. It's only a single BRAF mutation. But we knew that genomically that there was a pathway to high-grade transformation. And so it caused us to act more quickly, and with our preoperative mapping modalities and then intraoperative mapping modalities, we're able to create a situation where we could actually achieve the exact goal that the patient wanted. And so now she's off, I suppose, trying to get pregnant. So we'll to be continued.
Great case, very challenging with a good outcome. Just interesting, a poll of the panelists, who would have tried to do a BRAF inhibitor first before resection, and who would have done the resection? Anybody would have done it differently? I think I would have done it the same way as Duke on that.
Probably in the future, that would be a consideration. Now I would do the resection. And honestly, I've done it both ways with awake versus a sleep motor mapping, and I agree with Duke. I 100% would like the awake motor mapping, and but you just can't tell when they're asleep when it's all or nothing. So getting that awake subtle change in strength is really invaluable. So great job.
Yeah,
I think the final, to that point, John, I think that and Mike, I think we have no real data as to the I guess the efficacy of BRAF BRAF inhibitors, even in simple pilocytic astrocytomas where you've left a small amount. So I think that so we've had 1 or 2 cases where it's really worked quite well, and we have many cases where the tumor has been static, and some where the tumor has grown. So I think that would have been my reluctance, and also given the fact that she wouldn't wouldn't be able to get pregnant on a BRAF regimen.
Dr. Kalkanis, any thoughts?
Sharing my screen.
Sorry, I think I was on mute. I'm not sure if you heard that. I totally agree. I would do the same. I think this is a great case, a great example. I don't know. I didn't hear the results of the poll. But would people do the BRAF assessment?
With the treatment, we said surgery, I think.
Yeah,
I would go forward with surgery.
That's what I would do. I mean, again, it's surgical judgment, right? It needs to be done. So, I mean, at the end of the day.
Yeah. You know, interestingly, I have a similar situation, but a different location of the tumor, where same pathology, BRAF, but it's a thalamic lesion that's the large ventricular component to it. And we had a heated conversation in our tumor board about whether or not we should debulk, knowing that you can't get a gross total resection. I think in this case, there's a very good chance with great surgical technique and having that window that you found so eloquently that you could get a really meaningful resection. In the case that I kind of decided to do BRAF and BRAF at first was because 50% of the tumor was in the thalamus. And so we're hoping that it will reduce in size to a point where it could be somewhat manageable or treatable with that, because we knew it couldn't be. So it's a fine line of knowing safe or non-safe. A great case.
Well, that goes back to my liquid biopsy thing from earlier, that treating with the medication first and gives you a better chance of getting something meaningful from a surgery.
Yeah, I totally agree. And I think, to get to Dr. Sherman's point, not only before, but also after surgery, after Induca surgery, it'd be helpful to know what happens with that BRAF and is there something else that pops up over time, particularly as she, ages.
Right. Yeah.
Okay, Dr. Sherman, last case.
Yeah, so I'm going to talk a little bit about something that I was working on when I was at GW, and we're just getting the process going now that I'm at WVU. But I first want to thank Michael and Rick for the invitation. Really fantastic talk, Steve, and it gives me perspective. When I see talks like that, it just makes me wonder, how can I get a hold of that stuff? Like how, when you talk about getting access to the clinical trial networks, and when I was at GW, my clinical trial network was me calling, David Schiff down at UVA and whatnot, and saying, what clinical trials do you have going on? So being a part of a network like that, I think, is fantastic. And, now that I've moved on to WVU and we really have an opportunity with our neuro-oncologists working in collaboration with perhaps your group and expanding it out nationally. And, that's something that I'm keen and interested in, because I think it gives all of our patients opportunities, even if we're not directly near your institution. So I really, I always enjoy seeing your talks, and it gives me perspective on what things I as I said, want to bring to our own institution. So thank you for that. And also my co-panelists, it's always nice to see everyone, since we can't see each other nationally. I'm, as I mentioned, I just started at WVU about a month ago, actually. And so we're just getting going. And one of the things that it's been near and dear to my heart is virtual and augmented reality. When you talk about, helping out with regard to the patient, with regard to resection, but I think there's a lot to it. When I was there and now, transitioning over, I have the same goals, and we have such an opportunity, and I'm linking with the Rockefeller Neuroscience Institute to bring this to fruition when it comes to patient engagement, surgical planning, education, and also rehabilitation and pain management. There's a lot you can do with it. And when you talk about innovation and precision care, that has a lot to do with it too. And I'm actually working with the team of neuropsychologists when we talk about precision, medicine. A lot of that goes along when you have a brain tumor patient. You really have to consider, and this is something that I've been thinking about for a long time, pre and post-operatively, can we really maximize our patient's outcome? They talk about best outcomes for patients that have a better disposition, a better perspective on their outcomes. And so we're working on a protocol. It just started about a couple weeks ago, of linking. We're actually linking with a neuropsychologist that's done training with down in Costa Rica, who linked over to, he worked with Hugh Defoe. And so he's helping us kind of develop a protocol that says, how do we evaluate our patients pre and post-op from a precision, is there something unique about how these patients are experiencing it? So that's a whole other thing down the road. But what I want to talk about today is really, what we are working on to help us, better understand how to treat our patients from a preoperative planning and intraoperative planning. So, virtual and augmented reality has been something that we had for about 5 years. Now, as I said, we're just getting it going, and it has so many uses. And when we really think about it, you know, how do we explain surgery to our patients, and how do we plan things out? And so, can you hear this?
No, we can't hear the video.
Okay, so that's all right. The video is just showing that, you know, you have a patient that's literally wearing the headset. And so this is the patient example. So you have a 60-year-old patient, and just to give perspective on patient engagement and planning, this patient was referred from a local neurologist, and they lived in not too, long before they came to me in Cleveland. And so they were actually planning on going to Cleveland to get treatment before they came to see me. And so they had an occasional spastic movement in her right arm and some dysesthesias in her right leg. And so the MRI revealed a sub-centimeter area of flare. And so they weren't sure what that was. The neurologist locally put her on anti-epileptics, on Tumor. And so, 1 year follow-up MRI showed 1.5 or 1.5 centimeter lesion. And so, this was a case I did before I left GW. And so you look at it and you have something like this. And so, when you're looking at this, so one question becomes, how are we going to biopsy this? And how are we going to, liquid biopsy could come into play nicely in a patient like this where you're going to have risk. How are we going to do this safely? And then, what's our real goals of surgery? And so we came up with a plan using, virtual reality. And so we planned this out, and I tried to do this on our 2D system. And so the reason it says plan 1 is because I looked at 2 or 3 different plans, trying to pick the direct access to get the maximal amount of a biopsy. And you can see a lot of this was cystic. And so we did preoperative DTI and fMRI and all that. And so that's what we ended up, we had that. So we have this, we planned this out. And, as I said, we had 2 different trajectories. The third one we kind of knocked off immediately because that was more anterior once we had our DTI. And so essentially she comes to the clinic, we don't have any of this prepared. We get the fMRI and the DTI that, later that week. She comes back to the clinic, and she never went to Cleveland. And so it helped from a patient engagement perspective for her to understand, but not only from an understanding perspective, it gave us perspective on how we can safely get to this. And so we end up, just doing a standard needle biopsy, but it was quite a sharp angle to get there. And we wanted to maximize our resection. So then once we, when I say resection, I only mean that we wanted to maximize the amount of biopsy material. And I don't think I could repeat this, but we managed to take out the entirety of the cyst. And so all that cyst came out with one fell swoop. And it was only because from the preoperative planning, we were able to, evacuate the cyst because we took the long axis to the mass. And so, and then the other thing that can happen afterwards is patients always want to get, a video of what you did intraoperatively. And so we provide this to the patients now. And so they get a HIPAA compliant video, and you can kind of see, what was left over from a flare signal. And that was the non-cystic portion. And so, the interesting thing that I find about a case like this is that, the patient leaves, you can leave immediately post-op day 1. They have, she had no deficit, and we get a diagnosis. And so this is when it comes to the precision side. So we don't have time for, I have 2 other cases which we don't have time for today, but this patient is a grade 3 astrocytoma, IDH mutant, MGMT methylated. And the reason that that's interesting to me and I think for all of us, is if we go past another case, here's a glioblastoma. This is a patient that we use Gleolan, and this is an IDH wild type, MGMT unmethylated grade 4, right? Our third case, this is an MGMT methylated IDH wild type glioblastoma. What's the issue? Every one of these patients, different pathologies, really, were all treated with Tumor radiation. And so, if you looked at case 3 here, this patient has a little dot here, so they have multifocal disease. This patient had, technically gross total resection from our 5-ALA. So we had good resections, and, they all got treated with the same drug. So the reason I bring up about the virtual reality, I think for me, it helps. I feel like I explained to my patients better, but I think it plans out things better for me with cases. But I would be interested with the panelist thing, from as we move forward, this is a patient that we sent, we were working with the NIH at the time. We sent it over there, and they gave us a smorgasbord of molecular data. and genetic data, and we didn't do anything with it. And I know we don't have any real avenue to do anything with that data now. But as we move forward, I think from a precision medicine case, these 3 patients who all had different tumors technically should have different treatments. And so I'd be interested to open up the panel, how, Steve and the others, where you think this is going and how long will it take to get there?
Thanks, John. Great cases. Anybody want to add?
John, I would just say you highlight the essential challenge here, and that we do have this technology, but sometimes you get a phone book back, and it's irrelevant to make a clinical decision on, and sometimes you're left with just your judgment, like we talked about earlier. I don't know that we do anything differently. I think we do this because rarely, but not a zero chance, you get a hit, you get a unique target that might be relevant for a patient, and there might be a clinical trial. And that chance has really, I think I've seen it go from 1 or 2% to maybe 10 to 15% of the time. So obviously still the minority of patients, but for us, it justifies going through that exercise. But at the end of the day, we still don't have an answer for the vast majority of people.
And that's where, like, your network that you've created with regard to the Midwest, with the different centers that you mentioned, and with the Agile trial, I'm very interested to see as these develop. I know it's challenging with clinical trials and you can't have too many centers involved with them, but as you have access and we expand our access across the country, then it would be nice to see what other people are doing more readily, because I feel like every center is kind of doing its own thing, and until they become phase 3. And I think there's an opportunity to expand that network somehow. That would be great, so that we could reach out and say, hey, what IDH mutant drug do you have, or something that's something that would be better than just standard of care.
100%. And that's the hope and the goal of Agile, and it's not dependent on any one institution. It's this concept of real world data. So hopefully it works.
John, one question for you is, with the augmented reality, we're using that here as well, but obviously I want to know, for showing patients ahead of time pre-surgery and helping with their anxiety and understanding of cases, do you screen the patients to find out who wants that information, or are you doing that for every patient, and how has the feedback gone so far with the patients you share that with?
So I was trying to do that for every patient. We didn't have the system set up. Now kind of I'm in a very fortunate position where I can kind of set it up exactly how I want. So we're planning on doing for every patient, and that's not just for brain, it's for spine as well. And I will tell you, I give the patients the option. So most patients actually don't want to put the headset on. The families do, ironically enough. So they'll sit there with the patient not wearing it. But you can, that 360 reconstruction, that you can you can just show them that, and that actually is what majority of patients get. The fly through comes more in handy for residents and medical students, to be honest, but when the patients are interested, it really is kind of it is eye-opening for them. But I would say that's probably 20% of the time, because also it can make you a little dizzy if you've never done it before. That's why you see here in the picture the patient sitting down. So, but more often than not, it's literally just showing the 360 reconstruction, or literally I'll fly in for them and show them show them different vantage points, from me being the with my avatar.
Got it. Thanks so much. Well, I know we're already at 6:30, so and I don't want to steal any more time from everybody, but those were just some phenomenal talks, and also I wanted to say a belated happy birthday to Dr. Kalkanis. I know he just had it this weekend, so happy birthday, Steve. And thank you all again. I really appreciate it. Hopefully we'll get to do this in person real soon. And until then, I hope everybody stays safe.
Thanks. Thank you. Now, I just, again, to reiterate, just what an amazing, sort of, set of talks you guys have put together, and really, the fact that, you and Rick and Dr. Morcos have taken this opportunity to really, fill a void that has existed since COVID hit is really remarkable. So thanks, Mike, and keep up the good work.
Thank you.
Thanks, everyone.
Thanks, Mike.
Thanks, everyone.
Thanks, guys.
Bye.
Bye-bye.